So, good morning everyone. Today we will have a short talk about uh, tumors of the bones. It's a case study. We'll have some cases and we will discuss it together and we'll see what will happen. I hope you are good in musculoskeletal and bony tumors. So, first of all, let's start with this one. So, find the lesion. Where is the lesion? First metacarpal. Okay? So, it's in the first metacarpal right there. Good. So, this is a lytic bone lesion. We will leave it at that. No need to continue. We'll go to the first case. So, case 1. We have a 16-year-old white male with pain in his left upper arm. There is some mild swelling, mild tenderness, progressive pain getting worse for 3 months, and recent onset of mild fever. Okay? So you have the complete clinical history. We did an X-ray for him, and this was his X-ray. So, Shireen, what do you see? Frontal X-ray of the left arm.
Yes, of skeletal mature.
He's a mature patient.
There is
A what?
heterogeneous lesion that is involving the proximal shaft of the femoral.
Proximal shaft of the femur is involved by a.
Heterogeneous lesion,
It's a lytic mostly.
mainly lytic.
Yes.
With some soft tissue component.
Okay.
There is also periosteal reaction.
Good.
I see some cortical breach at that area.
Some periosteal reaction and some cortical breach right here.
There is a wide zone of transition.
It's an ill-defined wide zone,
Yes.
destructive lesion mainly, right?
Picture of an aggressive lesion. And
Okay.
according to the history, this could be an inflammatory like osteomyelitis.
Could be an osteomyelitis
Or
or
it could be neoplastic change,
neoplastic like what?
like osteosarcoma
Or
or Ewing.
Ewing. Okay, so let's go to a magnified view. Let's see it better. If we magnify this, we will find this thing here.
This is a granular periosteal reaction. Could be Ewing.
Okay. We have some periosteal reaction. It's like onion peel, kind of an onion peel. So here we have the onion peel appearance, and we had a biopsy and showed infiltrative neoplasm of tightly packed round cells with scanty cytoplasm. That's called round blue cell tumor. Okay, so this indicates what? Ewing. Keep in mind, when you see the lytic nature, it's mostly Ewing, not osteosarcoma. Osteosarcoma usually gives you some destructive sclerotic pattern, but lytic ill-defined pattern, that's Ewing sarcoma. Okay, and always Ewing sarcoma presents with a large soft tissue component. Okay, so MRI was done and MRI showed this ill-defined lytic lesion involving mainly the bone marrow, destroying the cortex, okay, with a soft tissue component. Again, another image you can see here, the the annotated image, and you can see it here and there, and it is Ewing sarcoma. Bone scan was also done for this patient, and you can obviously appreciate the radioactive tracer uptake in the malignant lesion, and there are no other areas of uptake. So this was a case of Ewing sarcoma or PNET. It is the second primary bone malignancy in kids after osteosarcoma, mostly from 5 to 15 years. It's much more common in Caucasian, and that's why we said a white male patient. Okay, usually in the diaphysis of long bones or in large flat bones like what? ilium,
Iliac.
mainly iliac bone. It happens there a lot. Okay, it has a permeative margin and some periosteal reaction causing the onion peel appearance. For example, you can see in this case, this is the typical onion peel appearance that is suggesting highly malignant lesion. Usually osteosarcoma, Ewing sarcoma can be osteosarcoma. Sometimes osteomyelitis also can have this. لا الليمفوما تيجي بسوفت tissue component, big soft tissue component, but it's in the possible in the differential, but not يعني much rarer bone marrow bone lymphoma, primary bone lymphoma than Ewing or Pinhet, especially in this age group.
And it is intramedullary mostly. Lymphoma, leukemia mostly intramedullary.
هي الإيوينج هم intramedullary بس الليمفوما واللوكيميا أول شيء البون primary bone lymphoma they are very rare. I've seen only يعني few cases, 3 or 4 cases, and usually presents in older age group around 40, 50, 60, something like this. Depends on the lesion, depends on the pathology, depends on which part of the body. كل شيء إلى شيء. Next step is biopsy. And then you go for full body CT scan to look for metastasis and then go for treatment.
MRI because it is scientifically you should go to MRI or
So, no, يعني MRI has يعني no radiation, okay, and it's good for intramedullary component of the tumor. Of course, the patient should go for a CT scan for staging purposes, but staging usually after diagnosis, not before.
and it is diagnosis could be done by X-ray or
Well, it's radiologically speaking, we can't say there is a highly suspicious bone lesion. Biopsy is needed for histopathology confirmation. We have to do a biopsy.
دكتور يعني local extension of the tumor by MRI.
In the bone, yes, by MRI, of course. Skip lesions, exactly. Yeah, exactly. So let's go to the second case. Second case here we have a 33-year-old black female, sudden severe hand pain after very minor trauma. She's completely healthy otherwise and all her labs are normal. So let's do an x-ray of her hand and see what's going on. So this is an easy case. Let's see who is one of the primaries. يلا عمر.
X-ray of the AP view and lateral view of the hands
Okay.
shows
Juxta-articular
osteoporotic changes.
osteoporotic changes. I don't agree with that. She's a young female. Osteoporosis is not very. Look carefully. What do we have? What's going on? What's going on here?
Yes, there is some sclerotic and
This is lytic, not sclerotic lesion.
sorry,
Where is it located? Cortical, intramedullary, intramedullary, lytic. Well defined, ill defined.
It is well defined with sclerotic margin.
Well defined with sclerotic
Surrounded
margin.
by some periosteal reaction.
I don't think there is any periosteal reaction, but let's see. So, what's in the lateral view?
So in the lateral view there is fracture.
There is a fracture. So, what kind of fracture? اصبرونا دقيقة خلينا نحكي. What kind of fracture is there?
Pathological.
It's pathological because there is a lesion. So, what is the lesion that is the most common lesion in the hand, and what its main presentation?
Chondroma.
In chondroma, it's very common, or the most common lesion, benign lesion of the hand bones, and most commonly present with pathological fracture. It is asymptomatic, patient have it for years, and minor trauma, bone breaks, and gives you, or gives the patient, not you, a pathological fracture. Okay, you can see here and you can see there is the fracture. So, in chondroma, it's benign cartilaginous tumor. We have to distinguish it from low-grade chondrosarcoma, and this usually by biopsy. It's not that easy to differentiate radiologically. It's in the act. اي
تقريبا متأكدين انه كوندروما بس لازم نسوي له بايوبسي.
لا هو ما يسوي له بايوبسي، هم يسوي له سيرجري. هذا ما راح يطيب راح يسوي له كورتاج and they send it the bone fragments, pathological fracture. They have to do curettage and bone grafting, and they send the pieces to the pathology to confirm in chondroma. It usually occurs in the acral bone. Acral means hand and foot, in the distal bones. Okay? Solitary, incidental, non-painful, unless there is a pathological fracture. Get hand films and look for lucency, not so much as a cyst. It's more kind of ground glass appearance, not like very lucent like the cyst, a little bit denser than the cyst. And look for stippled calcification, that is cartilaginous calcification. It's very pathognomonic of cartilaginous tumor. They called it rings and arcs. Rings and arcs of calcification. So, now, for the board and the ward, طلاب البورد وطلاب الوard. Multiple enchondromas equals earlier disease. Multiple enchondromas plus hemangioma of soft tissue equals Mafushi syndrome. Good. Good answering. Now, let's go to the third case. In the third case, we have a 50-year-old white male with back pain. 50, white, male, backache, back pain. Mainly in the lower spine, sacral, progressive for about 8 months. I'm giving you the entire clinical history. New onset of rectal pain and constipation. Based on the clinical history, what do you think? You are thinking of chordoma. Well, let's see. Are you all right? Yalla Jinan. So, what do you see here, Jinan? Exactly, that's what I'm asking. The first one, was it? No? Excellent. Rectal ultrasound. Showing?
Showing well-defined mixed echogenicity of the lesion.
Of a lesion.
Side of the rectum.
Okay.
That's
Now,
all things.
let's go to the CT
While
scan.
on the selected image of the pelvis, pelvic CT IV contrast
Shows
a mass.
a mass,
So there is a well-defined presacral mass.
presacral.
يعني associated with the mild fat infiltration.
I don't think there is a fat infiltration here. The fat looks good.
There is no bone erosion,
But-
I think.
But what is suspicious here?
Well, bone erosion.
Yeah, there is bone erosion right here. You can see this area here and this osteoporotic nature of the adjacent sacrum.
There is preservation of the fat planes between it and rectum.
Good. Preserved fat planes. Now, let's go to the MRI.
There is the
What is the sequence?
fat sat T1 post contrast fat sat. T2 fat sat.
You are a finalist. What's this image? T1 or T2?
T2 stair.
T2 stair or T2 fat sat. Sagittal, coronal or axial? Sagittal. You cannot make this kind of a mistake again. Okay? No contrast. This T2. I'm got it enhancing. Baba, mark contrast. Yeah, enhancing. It's hyper intense on T2. زين. So it's hyper intense on T2 and the شلون نقول يعني attracting thing or important or distinguished thing is the involvement of the adjacent sacral segments. Okay, that's S3, S4, and S5. So it is involving the adjacent bone. Okay, like here, here, and there. So we go on and do an FNA or a biopsy. In fact, it's a biopsy, not an FNA. Anyway, so طبعا what kind of biopsy is that? Ultrasound guided, CT guided, MR guided, CT guided biopsy, and it was a chordoma. Dalal, what's the two most common sites of chordoma? Dalal انتي؟ and clivus, skull base, exactly. Okay. So it's arises from the notochord remnant اللي هو the spine usually at the end of the sacrococcygeal or cervical, the clivus I mean. It's more common in males, usually middle-aged. It has a S100 epithelial marker positive staining, locally invasive until very late in the disease where metastases can go to the lung, lymph node and skin. So it's slowly progressive. It is not an aggressive tumor. It is slowly progressive malignant lesion. Okay? Now, let's go to the case, the fourth case. Let's see what's going on here. It's a 21-year-old male, new onset of chest pain. Today, worse on inhalation. Okay, it's ongoing aching leg pain for the past 6 months, which he has put off seeing a doctor for. He has the pain, he does not go to the doctor. Okay, so he has leg pain and chest pain. Let's see the chest and the leg and see what's going on here. Iman, yeah. What do we have?
Front view of mature skin of chest,
Chest, magnified view.
magnified view, and the frontal view of the leg of mature skin also.
Okay, leg also showing.
And the leg,
Let's start with the leg.
in the leg I see like ill-defined mass in the distal diaphysis of the tibia.
Okay, ill-defined
But I
mass.
see like a white zone of transition.
Is it lytic, sclerotic, dense, lucent?
Sclerotic lesion.
Sclerotic
Mixed
lesion.
with Sclerotic mostly. I see two lesions. One in the distal diaphysis.
We have one here and we have one here.
I see like a cloud-like calcification.
There is
One
a
with soft tissue
cortical thickening also of the adjacent bone, and there is bone marrow involvement. You can see the bone marrow is involved. It's irregular. It's radiculated. It's not okay. Now let's see the chest. What about the chest? This is a magnified view. Do we have anything here?
calcified foci. I see like
Look carefully.
yes.
You have to see it. No. There is a what?
A pneumothorax.
A lucent line
Yes.
with no lung markings distal to it, confirming a what?
Yes. The pneumothorax.
A pneumothorax. So what do you think of?
I'm thinking of osteosarcoma with metastasis.
Excellent.
Of pneumothorax.
Because osteosarcoma is one of the most common tumors to present with lung metastasis, and the lung metastasis usually cause pneumothorax in cases of osteosarcoma. Okay, so it's the primary bone number one primary bone malignancy. It has bimodal age, usually less than 20 years old present. However, there is another peak at the elderly. من يصير عندنا بالelderly? Who elderly comes with osteosarcoma? With Paget disease, exactly. Paget disease in the elderly associated with osteosarcoma. Also, history of radiation or bone infarct can predispose to osteosarcoma. And most patients die of pulmonary complications after metastatic seeding of the lungs, which is most commonly pneumothorax. Yes? Yes? It's periosteal reaction. It's a metaphyseal tumor and 60% present at the knee, distal femur or proximal tibia, and the radiographic terms to know, you have to know what do we mean by Codman triangle. This is a Codman triangle, elevated periosteum in a triangular way. It is suspicious for malignancy, and you have to know what do we mean by sunburst appearance. It's like sun rays, sun reaction, or also known as hair on end. نفسه هو sunburst.
Here the cortex is intact. There is no bone destruction.
Where is it down the
Cortex in bone here.
This is first, this cortex is not normal. It is densely calcified, densely sclerotic. So the cortex is involved first. Second, as we said, osteosarcoma usually present with sclerotic changes, not lytic changes. So there is no bone destruction, there is bone sclerosis and widening and irregularity and all these things, okay? So for the future surgeon, rotationoplasty is a new solution for disfiguring surgical resection of the lower limb sarcoma. They resect it and they do some kind of rotational plastic surgery to keep the lower limb functioning, okay?
What is the idea of this rotation?
To resect the bone. See this foot is بالعكس صاير. His foot, one is anterior, one is posterior.
Work like a joint, knee joint.
Yeah, exactly.
And you benefit.
Functional benefit. Functional benefit. So, let's go with some quick hits, some short cases. وين وصلنا؟ يلا بيام. Diagnosis. Short case. No. منو؟ برزين. Gout. Excellent. This is a gout. Let's go for an incidental finding on a knee X-ray. What's this? So exactly, a fabula. It is a posterior sesamoid or little kneecaps. هي يعني fabula مثل الباتيلا بس posteriorly. Okay. Now another ACAR, simple one. 13-year-old boy with superior tibial pain. انت ACAR? Give her a chance. Osgood-Schlatter disease. Good, excellent. Which is fragmentation of the tibial tuberosity. Okay. Then, surprisingly, this particular case was a metastatic disease. So, the metastatic disease in the bone, it's the most common malignant lesion and the third in the list of favorite places of mobile cancers to go. Malignant lesions are more likely to be in the axial bone. Multifocal, but renal and thyroid carcinoma are notorious for producing only solitary lesions. So, thyroid carcinoma and renal carcinoma, renal cell carcinoma, they produce a solitary lesion and they can be lytic, sclerotic, or both. A mnemonic to remember: lung is lytic, prostate produce, breast does both. Lung lytic, prostate produce, lung both. Okay, sorry, breast both. Okay, now the metastases that commonly spread to bone includes lung, prostate, breast, and kidney in adult. The most common طبعا, everything can go to everywhere, but the most common lung, prostate, breast, and kidney in adults, while in kids it's neuroblastoma, Walden's tumor, osteosarcoma, Ewing's, and rhabdomyosarcoma. These are the most common primary tumors to go to the bones. Okay, so thank you all. That will be all for today. Hope to see you again in the coming weeks. Bye bye.